Go ahead, Andoni.
Okay, thank you very much for the kind invitation in English, in Greek. Okay. Okay, so we're going to show you our case. It's a TAVR implantation in a female with small annulus. I'm very relieved because we chose a self-expanding valve because we have heard so much in the previous talks, so we have no conflict of interest. So our case is an 88-year-old female with hypertension, dyslipidemia, diabetes. She has coronary artery disease and she's very much autonomous in her everyday activities. So she has an EHA score of 3, a good LV injection fraction of 50%, a severe aortic stenosis, and this is our risk scores. So for many of you in Greece, it's still obligatory to have Euroscore 2 to perform a TAVI procedure. So this is our findings from the CT. So as you can see, it's a very small annulus because if we're going to see, it's, the area is 272 in the annulus and 269 in the LVOT. So regarding the previous discussion that a small aortic annulus is below 430, so it's actually a very small annulus. But we had the coronary ostia are about 10 millimeters, so we didn't expect any much trouble. So this is our findings from the aorta and from the femoral arteries. You can see there that there is some kind of calcification, and we expected some kind of problem during the closure of these legs, but there was no severe tortuosity in the aorta, just a lot of calcification in the abdominal aorta. So our procedure setup, and we normally use this in all of our patients, is we use sedation with opioid-free anesthesia. It's a combination. It's a protocol developed by our anesthesiologists that are still present in our operating room. We use via the left femoral vein a temporary pacemaker. So where we use the left radial artery for the pigtail, we're going to use 2 Pro-style for the closure devices for our femoral artery. We'll use the Cook sheath in the beginning, a 14 French sheath, and we would implant an Evolute Pro 23 millimeter valve, and we would not perform any dilatation before because there was not very much calcification in the annulus. So we can see now, this is our video. So at the beginning, we had some problems advancing our sheath, our 14 French sheath. So we changed the wire. This is a Landekrist wire, and we used this technique. We went, you can see it in a little bit, that we withdraw the dilator, and we could advance afterwards the guide wire much more easily. So we used the Landekrist because it's much more stiffer, and there wasn't any tortuosity, but there was some kind of calcification, so we just wanted to be sure. You see that using this technique, we were able to advance the guide wire, and we had no other problems afterwards. So in our hospital, even if we do not perform a pre-dilatation, we normally use a stiff wire to pass through the valve and not directly go with the stiffer guide wire. So this is what we normally do, and we don't change it regardless of performing or not pre-dilatation. So you can see that we have advanced the guide wire. So this is our first aortography, and you can see that we're in the right coronary cusp. So we normally don't do this, but in order, if we are sure that there is the right coronary cusp, we can go there, because many times you have a better view of the 3-cusp annular plane than if you're going to use the pigtail in the non-coronary. But afterwards, since we identified that this is the annular plane, we placed the pigtail in the non-coronary cusp. So we had no problem to advance the straight guide wire into the left ventricle. And we normally do so. We don't prefer to skip any steps, so we use a long guide wire, exchange it with a pigtail, and then go on with a stiffer guide wire, especially in this case. Then we had the Landerquist, and we did not want to advance the Landerquist over the Amplatz catheter. So I know in many centers they prefer to use not the long guide wire and not the pigtail, but we think that it's better to be safe and then to skip one step that usually doesn't take much time. So you can see here that we have advanced the pigtail into the left ventricle, and you can see here that if the shape is good and the position of the pigtail catheter is very nice, you can advance the Landerquist wire and have an excellent result. It is very well inside the left ventricle. That gives us a lot more support in order for us to then go on with the implantation of the valve. So this is another step that we normally do. It's necessary to see if the valve is very well positioned. And in our opinion, if you're going to do a pre-dilatation, you should do this before the pre-dilatation, because afterwards something happens, you must know that the valve is correctly positioned. So now you can see that the valve is advancing. So with the Landerquist, it's very stiff, so we do not expect any problems in the abdominal aorta. So you can see here advancing very slowly. Here is the point that we had some kind of problems before, but now with the Landerquist and a slightly push, we were able to successfully advance the valve. So now as we are approaching the aortic arch, we didn't have any problems. And at the beginning of our TAVI program, we normally use the three-cusp view, but I think it's now 6 or 9 months, maybe a year. We normally go with the cusp overlap projection in order to implant the valve. So you can see here the valve and how is it related to the annulus. So we will normally now start to deploy the valve. We normally do some small injections in order to have a very exact position of the valve regarding the annulus. So you can see here that it's a very smooth deployment. We check regularly for the depth. So we can see here that the depth is satisfactory for us. So we continue with the deployment of the valve. We normally go not for a very, we use the pacemaker to go about 100 beats per minute just to be more stable, the valve. We have seen that it actually works for us. So this is our projection now. You can see that from the non-coronary cusp it's okay, but from the left, some may say that's a little bit deep. But regarding that the valve is centered, and we're thinking that if we are going to release it, it will pivot towards the left of the scene, and we will have a very good result. So in this time, we change the projection and try to see if in the three-cusp view how it looks. So we normally go from 2 or 3 sides, and you can see here from a very slightly different projection that it's okay, and we're going to release the valve without any problems and without the valve migrating. We see that it is fully now unhooked. And this is a very strong, in this time you have to be very sure about the cone that has to be centered, because it may dislodge the valve from the annulus at the beginning. So this is a very important step, and we always take time in order to do this and to be completely safely. So you can see from this also that there is no regurgitation. It's a very good position of the valve. And we were very happy with the result, so there was no need for post-dilatation. So you can see that the first initial arthrography is done using a pigtail in the left ventricle in order to have some hemodynamics, and then we have the same arthrography without anything inside the left ventricle, and you can see here, you can see both coronary arteries, and there is no regurgitation at all. A very successful implantation. Afterwards, we did not have any problems with the closure devices for the closure of the femoral artery. So, thank you very much.
Well, that was a great implant example, and particularly you went through every step. This is a very challenging case because the vessels were small in the femoral arteries. You use the inline system. You exchange the sheath for the valve and straight up with the valve. I think that's a very good choice with the lowest profile possible and the utilization of the Landequist wire. I would probably caution against the utilization of the Landequist wire in the initial pass, and probably just favor that you take some other wire exchange over a pigtail for the Landequist before you put the sheath up. Some cases this is good, but some others maybe be some tortuosity in the aorta may be underestimated at the CT, and then cause some problems. So just be a little careful if that's your routine. If that's not your routine and you just use it in this case because you knew that the aorta is straight, then that's probably fine.
Yes, George, may I add something? Yes, it's not our routine, the use of Landequist. Here in our case, there was a problem with the advancement of the sheath because of the calcification. For this reason, we used the Landequist, and after we continue for the implantation, we didn't change for a Confida or for a Safari. Now, for the case, I think we choose the right valve for this lady with a small annulus. We didn't choose a balloon expander or something, another self-expanding valve. This valve was the correct valve for this lady, the correct also the correct size. We didn't have a paravalvular leak. We didn't implant a pacemaker after. So we were very happy after the implantation.
No, terrific. I think it was a great session that followed up the SMART trial results, then the satellite session, as well as a clinical implant from Athens Naval Hospital. Have any questions from either here? I don't see anyone in the chat. Any question in the chat? Thank you very much. That was great. Everybody, let's go to a 20-minute break. We come back 5 minutes after 2 o'clock.